Thank you very much. Before I start, I have to say, go Tigers. So, I'm really honored to be here. Just let me expand a little bit on the roles that I play at UTMB. I think that will help facilitate my discussion today. Like the introduction said, my primary job. I have 3 jobs really. I only get paid 1 salary. It's unfortunate. But the first job is Vice President of Telemedicine and Health Innovation at UTMB, and I run their entire business development for telemedicine as well as policy work, et cetera. Our telemedicine program evolved from a consolidated entity within UTMB into more of a federated component. And that works quite well. That allows me to do these other jobs as well as navigate some of the business requirements associated with telemedicine versus just a project that was funded by grants. And I manage the telemedicine piece with 2 other partners, the first being a chief physician executive who oversees all the clinical operations, and then the CIO who oversees all the technical aspects, obviously. The second job I have is CEO of the MBI, which is Medical Branch Innovations. It's a wholly owned subsidiary company of UTMB that is designed to leverage all of the inventions that we've had over the last 135 years in therapeutics, biotech, and digital platforms to commercialize that. So in the past year, we spun off about 5 different subsidiary companies underneath that as joint ventures with VC firms, other universities, and standalone companies. So, and then the final job is the main sponsor and architect of this thing called the Virtual Health Network, which is UT system-wide. And UT system is actually composed of 14 institutions, 8 of which are health-related and academic medical centers and medical schools. And so my job there is to put all 8 of those underneath one telehealth umbrella, so you can imagine the scope of what we're trying to achieve. And I actually will go into that in a little bit more detail. So the focus of today's talk is some models that we have employed, particularly around care delivery systems, and how we have leveraged technology to really enhance the work that we do. So as such, I'm going to be drawing from the 20-plus years of experience providing telemedicine and doing other care delivery models. Lastly, there's over 100 different telemedicine vendors that are out there. I mean, literally. And so I will try to remain objective and not name anybody in particular, but you can probably guess some of them, like the original founder of Teladoc, you probably heard of that company, it's multi-billion-dollar now, was in my department in 2008. He was working in his garage, basically, to found Teladoc, and then and it evolved from there. So really, really great success story. As you all know, the problem with, there's a lot of problems with healthcare. It's very complex, but 3 major themes pretty much dominate the past several decades, and that is access to care issues, coordination issues, particularly within and across systems, and of course, costs. So we look at these type of challenges, really, and see actually opportunities. So there's real opportunities here to really leverage technology to solve some of these problems. And these particular graphics are actually some of the market research that has been done out there on the market cap of telemedicine. These are really overblown research, in my opinion. I think really the current US market cap for telemedicine is around $6 to $7 billion, with 50% of that be going towards clinical services. So these guys are really optimistic, but just want to show you that a lot of people are raising a lot of money because of market research like this for various startup companies. So we actually have realized the power of technology to assist with delivering care since the mid-90s. Just a brief history, in 1993, the federal judge system, federal courts declared the healthcare in the Texas prisons unconstitutional, and they moved that authority outside of the state control into a receivership. The receivership then contracted with 2 institutions to essentially provide healthcare for all of the Texas prison inmates. The first institution is UTMB, which is us, and we took about 80% of all the facilities out there, so about 100 facilities located throughout the state of Texas. And the second institution is Texas Tech, who took about 20% of the remaining 20 facilities, and it's basically located in the Panhandle section of Texas. All of this work was actually done under one capitated budget. So we're actually a pioneer in population-based payment system. And if you go over that budget, you eat that cost. And that budget actually covers all of outpatient, inpatient care, ER procedures, everything you can think of in all aspects of care, including transportation and housing. So can you imagine moving and transporting those inmates across the state of Texas down to our prison hospital in Galveston? That became very expensive right in the first month of when we assumed this contract. So we started really looking at how we can leverage technology to essentially remediate some of these costs, and hence telemedicine was born in our institution. So to date, we see over 150,000 patients in real time every year across a host of specialty areas. And we've also expanded it beyond the correctional environment. We're in school systems, we're in employee health programs, we're in community mental health centers, community health centers, and as far south as the South Pole. So we actually take care of all the people on the ice down in the South Pole. And then in 2016, which is about 2.5 years ago, excuse me, the UT Board of Regents actually wanted to leverage the size and scope of all the specialty services across the 8 academic medical centers and medical schools to really offer world-class care and a net across the state to all regions. Hence, the virtual health network was born, and I was tasked to actually architect the entire thing and run it. So we're in the middle of our rollout right now. So the VHN is actually born of 3 phases. The first one is a demonstration, an assessment phase, and then a demonstration phase, which we are on right now with multiple projects being rolled out, and then a full deployment, which is what we envision this graph will look like in about 2 years. So what do? We're primarily a provider-based direct patient care using a hub and spoke model. We are, venturing into what they call DTC or direct-to-consumer. But before I dive into that piece, let's go over some general models of care delivery, so that way we have a point of reference to talk about. As you can see in a graph, the number of virtual visits are actually trending up. In general, you have 2 basic categories: direct care delivery and indirect care delivery. Really, novel, right? So in the indirect care delivery model, they're composed of telehealth programs and projects that typically focuses on the acquisition and transfer of knowledge and data that will guide and inform providers in direct care services. They include all of the telemonitoring models, such as wearables, geofencing, et cetera, associated with collecting information that will be sent to providers to guide on us, to inform them on the statuses of their patients. And then they also include programs that are designed to manage some kind of chronic diseases via supportive applications like goal setting and monitoring. And then another model that is really catching on, you probably heard of this one, that relates to what we call telementoring, is essentially Project Echo. You guys ever heard of that? It's actually based out of New Mexico to help rural providers manage hepatitis. And now it's actually expanded to other disease systems. Other states have actually adopted it. The state of Colorado, I know, has that line item in their state legislation, so they fund that completely. So it's pretty neat. We're a really, really great program. Struggled with sustainability for many years because it was grant-based totally, but now you have legislative support because the value of it for the rural providers is great. At UTMB, we actually have 2 programs very similar to that. One is focused on infectious disease. through our Galveston National Laboratory. So we collaborate with the WHO, CDC, and hospitals around the world for infectious disease. So, and then another one is aerospace medicine with NASA and some other space agency. And so basically what they are really virtual global grand rounds, is basically what these telementoring programs are. The next, the care delivery models can be viewed from two other forms. One is a provider-based, provider-driven model, and the other one would be B2B to C, direct-to-consumer model. So the direct-to-consumer models aim to essentially connect patients with providers at a large scale and often relies solely on technologies such as mobile devices and tablets. And in practice, these models are limited to servicing low acuity and non-emergent care, and that physicians, conditions that physicians feel confident in diagnosing via just the telephone or the video. And the primary revenue driver for these models, the direct-to-consumer care models, is some form of PMPM, or per member per month, and a utilization fee. So, and then the final class in direct care delivery model is a provider-based, provider-driven, that are typically hub and spoke models that is comprised of integrating telemedicine into existing provider healthcare platforms or health systems to either improve care or augment care. These models utilize complex medical peripherals such as otoscopes, dermoscopes, and various other things like that will allow for an actual physical exam at a distance. And so it opens itself up to other multiple specialty areas. And this is the one we use because we're an academic medical center. We have a lot of specialists. And so, and then the revenue driver for this particular model actually are pretty diverse based on that. You can do PMPM, you can do other things. And actually we'll go into that right now. But before we start into that route in terms of payment, let's look at some other emerging models that we are doing, and a lot of other folks are doing too. It's called integrated care. So when we define integrated care at UTMB, we're attempting to address the gap between physical health and behavioral health. So if you look in the literature, up to 25 to 30% of all of patients with behavioral health issues are first seen in the primary care clinic. And their cost of care is 2 to 3 times that of patients with just medical issues. So the typical approach to this problem has been the PCP treats the patient with the behavioral health issue, which works to some degree, but may not for complex behavioral health problems. And then they're already overburdened, so you have that issue. Then the patients are referred to a psychiatrist who may have, just a tremendous backlog associated with their schedule, and so most of the time the patients don't even follow through with the psychiatric visits, and then they end up in the ED. Case in point, for example, there's a large-scale hospital, not part of the UT system, that's in the Dallas-Fort Worth area. They were actually interested in contracting with us to provide telepsychiatric support into their ED because their ER docs were overwhelmed with behavioral health patients. They were so overwhelmed that they were willing to pay, for 2-hour blocks twice a day just to clear out these patients. It was amazing. And so they're actually doing it now, but not with us, it's with a separate vendor. The third legacy approach to this is actually quite novel. We co-locate a behavioral health specialist in the PCP office to provide that augmented care, which works, but you have the problem of economy of scale at that point because you have that one person in that one location. So, did it work? Nope. So using technology for integrated approaches based on pretty sound evidence, one is that when you co-locate a behavioral health specialist into a PCP, it's shown to improve outcomes for these patients. Second, behavioral health treatments via telemedicine has shown to be efficacious. What if you smash the two and virtually embed the behavioral health specialist into the PCP? And so it will offer a pretty unique advantage. So what we have done is we have actually taken it a step further and making it a teams-based approach. So here's how it works. The patient comes into a PCP office. The PCP identifies that there may be a behavioral health issue going on with this patient on top of the medical issue. And then the PCP treats the medical issue, moves the patient into an integrated office space with telemedicine equipment. The staff informs the behavioral health team. The team beams in, sees the patient, then consults with the PCP on treatment plan. And the patient can actually come back to that same facility and see the behavioral health providers separately from the medical issue as a follow-up. And then at that time, the behavioral health team can actually actualize other community resources to help this patient out. And then you can foresee, folding in other specialty. At UTMB, we actually, in 2016, started embedding our behavioral health providers via telemedicine into our primary care settings, particularly in the rural settings down in South Texas. And thus far, it's been really well received by the PCP as it provides them with augmented support for their patients. And now some of these patients, once they are stabilized from a behavioral health perspective, they're transitioned back to the PCP, who then becomes the true medical home for this patient, if you really think about that. And so how do we get paid for something like this, right? So a lot of you are probably thinking about that as docs. How do I get paid for this? So the PCP drops a claim for medical management. Our psychiatrist drops a claim for telepsychiatry. And the PCP facility can drop a claim for facility fees. Nominal, but it's a start. We've done that, but actually what we have done is leverage legislation to actually cover some of this stuff in grants as well. So right now in the state of Texas, there is a legislative bill that had just passed the Senate and is being voted on in the House, I think this week or next week, that will integrate behavioral health providers into the clinical medical nursing office at school systems throughout the state of Texas. So that's pretty unique. We actually are doing that already through a couple of grants. And so we have behavioral health teams beaming in into two schools down in the Rockport area of Texas who got hit pretty hard by Hurricane Harvey. So we're supporting those students in the community that way. So our teams are actually embedded in that medical setting, if you can really think of it that way. Oops. This is the old slide. I'm going to just skip this one. Just getting back on this one, another model that's really emerging. It was very similar to this, if you can replace the PCP with just like a cart system. It's happening in the state of California and a couple other states in the West pretty well. I know of a company that has like 12 clinics. It's essentially called on-site virtual specialty care. So some of the specialists are actually partnering up with PCP providers and leasing an unused exam room. And then also augmenting some of the support staff to help them with check-ins and use of the medical peripherals. This actually is working really well with cardiology, neurology, and psychiatry. So what they're doing is embedding, it's a retail specialty service if you really think about it. They're embedding themselves in PCP offices and providing specialty care. And so, as you can imagine, there are benefits associated for the patient, in terms of increased access to these specialists, and for the PCP in terms of, potential revenue stream and augmented services. So that's happening as well. And we're looking at that as, in addition to the current hub and spoke model that we have. So it's retail telemedicine. I'm just going to skip that model. So how do we get paid? So there are basically two government programs that you can get paid from for telemedicine, the first being Medicaid, and that's really state-specific. Every state, except for Massachusetts, has a reimbursement policy for telehealth, and you have to actually look at each state to really see what they are. Medicare is actually a little bit more restrictive. Historically, Medicare fee-for-service only reimbursed for live video service for patients in MSAs or HIPAA area. You guys know what that is, right? So I don't know, explain that. And so, except for store and forward in Hawaii and Alaska, but several key legislation has been passed in the last few years that actually has created tremendous changes in Medicare reimbursement. The one piece of legislation is the Chronic Act, which is the creating high-quality results and outcomes necessary to improve chronic care, and the FAST Act, which is furthering access to stroke telemedicine. They all have been introduced and is creating tremendous changes, and those changes include reimbursement for virtual check-ins to evaluate whether this person needs an office visit or other services. The second thing is remote evaluations of pre-recorded patient information, so essentially storing forward for video and images, and then interprofessional internet consultation. So for team-based approach to projects like ECHO, you're going to start to be reimbursed for that. And then changes to originating sites and geographical area for end-stage renal disease, as well as acute stroke care, and then new codes for physiological monitoring and chronic care management. They are also right now accepting comments for treatment of substance abuse disorder using telehealth. So I think that's a great positive move. In addition to the two government programs, which is basically fee-for-service, a few other payment options also exist, and these are unique payment methodologies. One is, of course, what the direct-to-consumer models and the telemedicine vendors use, and that is a subscription-based, which is basically a fee-for-access model, and they all include some form of PMPM and utilization fee. We at UTMB, in 2017, we started dropping claims, but before that, we exclusively relied on one payment model outside of the correctional system. We call that session-based billing. And essentially, in that model, clients pay for a flat rate for blocks of time. So in essence, what they're doing is we are guaranteeing availability of our specialists to these clients. And then we defer billing to them, so that way they can try to drop claims and recoup some of that cost. So what's worked for us in that area is psychiatry, particularly pediatric psychiatry, endocrinology, neurology, other stuff, outpatient neurology, and any specialty area you can probably think about. The next payment model that's really unique is retainer model. This actually works quite well in stroke care because unlike the session-based billing, patients with stroke don't come in at appointed time. They just come in whenever. And so the retainer model essentially is a monthly rate for X number of cases that are seen. So for instance, that hospital that I mentioned in Dallas is contracting with a UT institution to provide stroke care, and they pay in a monthly rate at some rate, and then they have up to 10 cases per month of stroke patients that walk into their ED that they can beam in any time of day, 24/7. And so as soon as they go above that number, that 10th patient, and go into 11th patient, it becomes an hourly rate after that. And then the next month kicks in, it goes back to that retainer model. So it actually works pretty well. With the emergence of more integrated systems and a move away from fee-for-service and towards an alternative payment models and value-based care, basically the graphs at the bottom, we see bundling of payments that wraps the use of technology to deliver care. One model that we have used for a long time, like I said earlier, is population-based payment models. And so the state of Texas every year pays us X amount to take care of 175,000 inmates, all aspects of care. And that, like I said, that's using technology was very early on for us to contribute to cost savings. And so now in our world, in our institution, we call telemedicine in that correctional environment as the default escalation of care. Essentially what they do is the patients, the inmates, see a telemedicine provider first, unless there's one on site, before they see anybody else. And then the care is then escalated as the complexity of the problem is revealed itself. Regardless of what model you use and how you have initially resourced your program, you must always consider sustainability. So for years, government programs agencies and various foundations have given millions of dollars in grants for telemedicine infrastructure. In 2006, there were 250 programs that were funded by grants for telemedicine infrastructure. Now, you go visit these programs, they're gone. And you see the telemedicine equipment that they purchase, it's boxed up in a closet, the vast majority of them. What started out essentially as noble intention to provide critical access to care is now a discontinued project when the grant cycle has ended, you know, so that's what happens. We never relied on grants except for the first few years of our telemedicine program, and if something is relatively new and innovative, like into the schools. We rely on grants to get it started, but then we figure out a sustainability piece. So how do you figure out a sustainability piece? You have to do a business plan. A lot of folks don't do that. This is the business plan for the virtual health network. This is it, the business model canvas, right? So you guys done a business model canvas? Great. So essentially, it's an executive summary of a business plan. And I created this in order to get money to essentially for the VHN. Since we have rolled out, we've only been in existence for 2.5 years in terms of rolling out that massive network. We have actually achieved a 1.5-fold in return in form of actual revenue to the institutions. Pretty significant in 2.5 years. So what does that mean? It means I spent $3.2 million in 2.5 years. I've already made $4 to $5 million in revenue annually for these institutions. And I'm just started, so we still have, we're in the middle of our rollout. So that's pretty good, I think, as a business. So the business model canvas is a great way to encapsulate, you know, what is your solution trying to address, and the value proposition that you are bringing to the table. And how are you going to go after those clients, what's your cost structure going to be, and what the revenue streams that you're going to try to enact. So it really lays it out. And this is it. I mean, it's not that rocket science. And we managed to get funding for this, and we're now making money. So the business model actually helped us design a connectivity infrastructure or architecture that actually leverages the specialty expertise across all of our health-related institutions to provide services to a host of programs, government programs, employer programs, other hospitals. So if you look at this graph, it's just actually our connectivity design. Each one of those bigger blue hospital is an academic medical center, and their unique telemedicine initiatives with satellite or partner institutions. Now, what if we connect them all together? And then what we can do at that point is something pretty cool. We call it, you know, we can actually do a pooling of clinical capacity to service the entire system and the state. So no one institution have to offer up just neurology. Now I can get it from Southwest, I can get it from other things, and then to treat both my patients and my partners' institutions. So you can imagine the possibilities of revenue streams that actually can come about doing that. So from that, you actually have key implementation steps that you have to do for a big program like a VHN. These are basically a high-level overview of the implementation steps that we had to embark upon, and they fall into 4 basic categories: assessment, development, deployment, measurement. You always got to measure what you're doing in order to know if it's working or not, and you need to change. The reason why this is important is because it captures key things that you need to consider and a lot of people don't manage. And that is, you know, the infrastructure, not just technology, but the clinical capacity, all of the contracting, compliance issues that you have to do. In addition, once you have something like this in place, it's a lot easier to scale because it becomes standardized, and when you can replicate it over and over again and really build it out. And so with this in place, we do this at every institution for every project that's rolled out. Some of it, you know, you skip over because you've done it already, but it actually allows us a sense of continuity and standardization that's replicable, and that's really important if you really want to grow your business. So the main takeaways in our 20-plus years of experience of innovating with care delivery is, 1, technology is a tool that supports your business goals. A lot of people, a lot of folks have the reverse. They see something bright and shiny and they say, oh, let's try to fold that into what we do or use it somehow. That is a waste of money and investments. You have to figure out what your business goals are and find the suitable technology to help you get there. That's what is the key for sustainability. Focus always on leveraging technology to provide value, particularly to the patient, because that's how people will start and continue to pay for your services. You know, being in a hub and spoke model, we try to replicate as best as possible using technology the patient to provider relationship and experience. That allows us to actually perpetuate a sense of continuity for those patients, so you retain them much more. Always engage early and often. This goes for all the stakeholders, clinical staff, technical staff, administrators, payers, everybody. We do a tremendous amount of reporting on a monthly basis. Different reports of different groups. But the more you keep people in the loop, the faster you roll out and the higher the buy-ins. And that's really important. And finally, always plan for sustainability. And the way I look at sustainability in business in terms of telemedicine is there's two analogies for the business models that you're going to use. One is, are you going to use telemedicine as a rake model to rake in referrals, or as a moat model to keep down costs, but at the same time provide quality care? So, or you can do a hybrid of both. Sometimes they exist. But that's how I think about first thing when people say, how are you going to use this and sustain it? I think rake or moat or both. And then you proceed from there in terms of planning for your business.